afternoon. This is Dr. John Bennett broadcasting from Miami, Florida. We have another episode of Radiologist TV, and we have the pleasure of having Ayden Jacob, a neuroscientist from UCSF and part of Radiologist TV. And I'll let Fike Sheikh take it over from here. Hello, Fike.
Hi, John. Thank you. Hi, everyone. I'm Fike Sheikh. I am the co-CEO and the creative director of Radiologist.tv, and I'm very happy to introduce Ayden Jacob, who is going to be talking about the future of brain imaging today. A little bit about Ayden Jacob is that he is a neuroradiological physics scientist at University of California. His past places of work include University of Pennsylvania and University of Oxford. He is a preeminent scholar in the field and has a strong focus on neuroimaging. And he also is the executive director of Academy of Medical Ethics in Bioinnovation, and is the chief editor of Journal of Nuclear Medicine and Radiation Therapy. Welcome to the show, Ayden.
Thank you, guys. Thank you for having me. I really appreciate it. It's nice to see everyone. Good to be back at Radiologist TV, and hopefully we could discuss some interesting brain science imaging stuff today. Congratulations on putting this together. Radiologist TV seems to be taking off fantastically, and it looks great. So it's good to be here.
Thank you very much. So we are ready to roll whenever you are.
So yeah, I was thinking what we would do is develop a series here, which we can even crowdsource the topics within brain imaging that our audience wants us to discuss, and sometimes we can bring in further experts on topics such as neuroimaging in brain tumors, neuroimaging in epilepsy, neuroimaging in psychiatric disorders, etc. So today what I wanted to do is open up a discussion for us to analyze, what are the current standards that are being used, or not so much the current standards, but how can we innovate in terms of the current standards that we're using to image the brain for various disease states, whether it be MRI, CT, things of that sort. We can also jump into Faik's specialty, which is nuclear medicine. There's a lot of nuclear medicine going on in neuroimaging as well, which Faik could speak to. So we can dive right into it. Pretty much prior to the advent of imaging within the skull, our only ability to diagnose a patient was simply through biopsy. So we were quite limited in what we were able to do. And through the utilization of medical physics, we've been able to develop over the past 6, 7, 8 decades, an ability to actually localize a disease state, whether it be a neoplasm or even a psychiatric state, to some sort of region in the brain. Now the ability for an imaging methodology to localize a specific area in the brain that is dysfunctional as it relates to an adjacent region in the brain is quite remarkable, because it's specifically through that precise diagnostic tool that you're able to then develop a treatment method. And I'm sure Dr. Kim and Dr. Bennett and Faik and everyone could relate to this, that one of the basic premises of the future of medicine is appropriate diagnosis and precise measurement in the diagnosis in order to develop the appropriate therapy. This is why we're seeing, personalized medicine of gene therapy developing so popularly amongst, both industry and in academic centers, because precision in the diagnosis is what is phenomenally important when we're dealing with such high-risk, high-stakes patients. So if the biomedical imaging community, radiologists, nuclear medicine techs, etc., everyone together is able to combine these technologies and their knowledge skills in order to really look at how are we imaging this patient's disease state, specifically in the brain, what are we particularly looking at, and then what are the appropriate and precise steps and mechanisms by which we can take to then treat that disease. I think that would enable us to influence the healthcare system in a tremendous manner. What do you, Faik, what is your take on this?
Well, I'll let you go ahead first, Faik, because you're the radiologist in the group. Are you there, Fike?
It looks like Fike's mic.
He
I
took a
think his
break.
microphone.
It's
Yeah,
okay.
it seems like his microphone is down.
Well, Ayden, let me just remark something, about the mixture of knowledges. There's so much happening in medicine now, not just in neuroimaging, but genetics, nanomedicine, which I guess you're a big part of, stem cell. I mean, all these sciences are developing it and you have to kind of mix them all. Is that what you're kind of talking about with neuroimaging?
So that's a good point, John. There are certain limitations to which you can invent the future of medicine. So, there's only so far we can push imaging in science, but there's a tremendous amount of terrain that hasn't been traversed. So we can't go out there and say that, we want to accomplish being able to give the, exact amount of gray dose to the tumor over X amount of time over and over using, some portable machine. That's not what we're saying. Or to make a PET MRI, CT, et cetera, scan. That's, we're looking at clinically viable and feasible things. Now we also have to look at it from the economical standpoint. So now that we're seeing more of an overlap between industry funding money to researchers being able to develop new types of bioengineered mechanisms which can image the brain, I think we will be seeing a lot more of innovation and inventions in this field. So, for example, in the past couple of years, MIT has been doing something quite interesting in which they build 3D visualization tools for the brain. And if you can do it in the brain, you could pretty much do it in other organs as well through the slices that they receive from images. So what this enables you to do is you have a 3D image of something without using a 3D printer. You have a 3D image of an organ prior to a surgery with the tumor in place without anything really being there. It's almost as if it's a hologram. Does that make sense?
Yes. Yes.
So the ability for these guys at MIT to develop that, it has huge patient impact because the surgeon can then practice on the tumor before going into the operation without, having to actually 3D print anything. 3D models are great, and they've done 3D printing for hearts prior to congenital heart disease failure on operations. The arteries and veins in the heart are so complicated that the cardiac surgeons had to 3D print the heart out of mass gen prior to the intervention. Here, what they're doing at MIT is they're gathering thousands of slices of images within the brain, sagittal and coronal, and they're building up a map of the brain for one patient at one time, enabling the surgeon to learn how to navigate through the brain of this particular patient. Whereas prior to this, image-guided therapy is a very fancy term that surgeons like to use. Well, image-guided therapy is a simple image, right?
Mm-hmm.
It's just, it doesn't give them depth, it doesn't give them width, it doesn't really give them much to work on. So the ability for us to conjoin these images together to give a 3D navigation map to the surgeon is a tool which surgeons can use quite a bit. And I'm sure Dr. Kim could speak to this as well. Then on the flip side of that, you have the ability to use imaging for educational purposes instead of cadavers. So if you're able to take 3D holographic images of a patient's brain and then implement that same algorithm to develop a method by which you could develop a 3D image of an entire body system, then the medical community would be able to train surgeons in residency and medical students without the utilization of cadavers. And people are doing this. They've done this with surgeons who are working in the United States Air Force, and they've built a collaboration by which they can simulate. They use the technology of Air Force simulation in which they had to learn how to navigate intercontinental terrain without actually being there, kind of like through a drone.
Mm-hmm.
They pulled out this type of mechanism in order to teach surgeons how to navigate the terrain of the human body without actually being there.
Mm-hmm.
So this is what I mean by interdependent and interconnected technologies affecting medicine.
Hmm. Yeah, it sounds like it's similar to flight simulation. Pilots have been doing that for a while.
Yeah,
I think they were one of the first groups to do it, first industry to do simulation like this. Is that what you mean, like that type of thing?
yeah, exactly that.
Okay. Um, Now, I wonder if medical students use cadavers now. Are they just using more 3D printed simulation? And
So yeah, most medical schools are still having students utilize cadavers because the technology to build 3D holographic images isn't fully there, and it is still quite expensive. But within a decade, it should be unanimous. I mean,
Mhm.
people should be using this because the cadaver, the ability to use cadavers at end is limited, but the ability to use a holograph is infinite.
Yeah, I saw an article about cardiology doing the 3D because in the heart there's a lot of anomalous vasculature. So, there's everybody has different vein, the different vessel structure in the heart, and they can be prepared for so they're not surprised as far as where the veins and arteries are in the heart. Now, I don't know if that applies to the brain too. I imagine it does, that everyone's arteries and vessels are different in their
Right,
brain. Is that
right.
is it an organ? I'm not too familiar with the
So there's
anatomy and the
certain
histology. Is a lot of difference in person to person as far as blood supply, where the vessels and where the
Yeah, that's a
veins and
good
arteries
question.
are?
So there's the subspecialty of neurovascular surgery is when a brain surgeon will need to, they spend a year of fellowship, delving into the vasculature of the brain to deal with things like aneurysms, AVMs, etc. And you do have your baseline anatomy. For example, every patient will have a circle of Willis.
Yeah.
So the base of the brain, which supplies, all the lobes with the appropriate amount of oxygenated blood over a given amount of time. However, and this is where neurosurgery gets quite complicated, every patient is different, not only in terms of the blood supply, but in terms of, for example, the pituitary gland, the hypothalamus, things of that sort. There's a pretty prominent surgeon out of Cedars-Sinai Medical Center who has a 2,000-page book on his desk regarding how the hypothalamus is different in every patient he operates on.
Really?
So this is why the extensive training goes as deep as it does, because once you're inside the head, you need to be able to differentiate quite quickly between different regions of the brain and what's going on in every single patient according to their anatomy. And the best surgeons are the ones who are able to do that almost as second nature.
Mm-hmm.
Now, John, imagine if prior to intervening in the patient, you were able to visualize and practice on these patients' specificities. So
Yeah, that would be great.
you'd
I'm
see
sure it's very like
two you'd see two positive outcomes from this. Um, you see a lower mortality rate post-surgery because of B, you'll be able to prevent unforeseen circumstances. So imagine you're going into an undetected terrain or an area that you're unfamiliar with. Well,
Mhm.
this is essentially what a neurosurgeon is doing. But if you're able to take an image of the brain prior to that and build up an entirely 3D map of what's occurring, both on the molecular and the anatomical level, the molecular level is not important when you're doing surgery. If
Mhm.
you're able to build up the physiology and the anatomy and the vasculature, which we are able to do, you lend hand to the surgeon being able to navigate quite freely as they try to traverse intracranial terrain.
Mhm. Well, I have a question. I know it's helpful for anatomy and knowing where you're going, etc. These 3D models, can they play any part in diagnosis? I mean, can you use the 3D model to say, hey, this looks like a tumor or this looks like something different? Or no, that you have to get a biopsy of it?
No, the idea is that we should be able to use medical imaging more and more and biopsies less and less, because
Less
with the
and less.
biopsy, so that's what we're hoping the future of imaging looks like. We need to, so right now there is, I wouldn't say a crisis in radiology, but we have an overload of radiologists, and radiologists due to telemedicine and sending things overseas, et cetera, et cetera. MDs are struggling. So they need to, I think recently one of the heads of American Society of Radiology was discussing how radiologists need to take back their field. And one of the ways of doing this is through innovation. We can't keep doing things the same way we did for the past few years. We need to innovate, we need to invent, we need to figure out ways to affect the clinical setting through practical and feasible innovation. And in radiology, this might very well be the ability to develop a 3D image for a patient, or to develop algorithms to better assess a situation under a limited amount of time. These capabilities will enable us to improve patient life to a tremendous degree, but they also take the cooperation between industry and academia. Industry having the funding, and academia, I believe, having the people to actually do it.
Mm-hmm.
As these two worlds combine, we will eventually see a roadmap to success, not just in radiology, but in medicine in general.
How much more powerful will this is kind of a naive question, probably, because I don't have a great background in radiology. How much more powerful will the MRI get? Is it increasing in power constantly, or has it reached a point where the resolution won't get any better?
So it's difficult to answer that based on the science behind it. So
Okay.
The MRI is basically working off of the magnetic field which exists and is generated, and as it interplays with protons in your body.
Mm-hmm.
And the vertices that are created through exciting those protons and then allowing them to go back to the relaxation state and acquiring a signal noise image from the excitation of those protons. The issue is how much power, so to speak, does that magnetic field have?
Mm-hmm.
And what is the threshold of the power we can administer to a patient in a safe environment?
Mm-hmm.
If we put a rat in a machine, an MRI machine, maybe we can, shoot up the Tesla to God knows what. But if you have a pediatric patient, you can't. There are certain standards which we haven't been able to cross.
Mm-hmm.
I think that if medical physicists and dosimetrists and radiologists work together, and radiation biologists, they would be able to find out exactly what is occurring in the human body upon induction of an MRI image, and try to develop manners by which you can increase the resolution of the MRI through an increase in B field, magnetic force, while limiting the amount of toxicity, so to speak, that you are administering over to the body.
Mm-hmm.
If we can do that, we'll be able to increase the resolution, which is something that physicians need tremendously. I mean, some physicians you'll speak to will look at an MRI and they don't know what to diagnose their patient with.
Mm-hmm.
And if you think about it, that's why the radiologist is given, they're very high on the food chain, I would say, because of their capability of understanding the dynamic of diagnoses across a broad spectrum of fields through looking at an image and training their eye to be able to tell this belongs to this category, while something that looks very similar belongs to a completely different category and thus needs to be treated differently.
Mm-hmm. Well, Omer, in his talk he gave last week, was talking about how radiologists communicate with the residents before they order a test. In other words, it used to be, I know when I worked in the emergency room, I kind of ordered the test and the radiologist interpreted it. He said that now there's more of a communication before they do a test. So the radiologist actually determines which test would be more appropriate. Do you know what I'm saying?
Very interesting. Very interesting.
Do you see that the radiologists are ordering more tests because there's so many new technologies out there that they need to get more involved in the clinical situation before a test is ordered? Because some of these tests are pretty expensive.
Yeah. So it's I guess a double-edged sword in that, on the one hand, you have the healthcare administration team, probably the CEO of the hospital, down the radiologist and physician's back, saying, order less tests because it's costing us a tremendous amount of money. And then on the flip side, you're having the development of this very interesting, cool type of technologies which could potentially help patients that are in very difficult situations. So in that situation, the attending physician is the one who is going to make the call on what imaging tests need to be taken.
Mm-hmm.
The radiologist is just analyzing that test. But the
Okay.
one who's actually saying what tests they need to take is usually the attending physician. And it's difficult because in some situations the attending physician is hesitant to prescribe a certain imaging test because of the repercussions he might face for the cost of that test from the administration.
Oh, okay. I didn't think of that point. That definitely is part of it. But Dr. Kim, do you have any questions for Ayden? Hello, he. You're muted. You're muted. You gotta unmute. Common mistake.
I
There
have
you
an
go.
interest in functional MRI.
Oh, nice to meet you, Dr. Kim. It's a pleasure and
Yeah,
honor to meet you.
yeah. I have an interest in functional MRI. It is possible to detect the cochlear nucleus or vestibular nucleus. Functional MRI can detect the abnormality of the function of them, vestibular nucleus and cochlear nucleus.
Right, so you're having the utilization of functional MRI in diseases like tinnitus, um, or you want to be
Vertigo,
able,
yeah, vertigo, tinnitus.
exactly.
Yeah, yes. So I have interest in about cochlear nucleus and vestibular nucleus.
Vestibular.
Oh,
What, ordering an MRI for that, Kim? Dr. Kim?
functional MRI.
Functional MRI. Okay, that's the fMRI, right?
Yeah, yes.
Are
So
those
what
used? Yeah, I think he's asking, are they used much for ear problems like the cochlear and
Yeah, yeah.
yeah, to kind of check out the inner ear.
Right, yes.
So there is a
Uh,
growing interest in the past decade for using fMRI in the entire auditory system, um, from brainstem nuclei to the actual cochlear centers itself. And there are lots of papers published on this. The auditory system, as it interacts with the brainstem, is highly complex, but we are able to utilize MRI at a specific bandwidth um, to indicate the particularities of certain histological centers in the brain. But I'm sure Dr. Kim knows a lot more about this than I do.
yes.
Do you
I have,
order that? Do you order them, Dr. Kim, for people with ear problems, inner ear problems?
no,
No, you
no.
don't. Okay,
Yeah, I have.
not usually,
Um,
huh?
but MRI is very much developed. If developed, I think the fMRI, just fMRI can find the cause of abnormality of vestibular nucleus and cochlear nucleus.
Now, if you have someone with an acoustic neuroma, is an MRI part of the workup, the
Oh
normal
yes,
workup?
acoustic neuroma has just dependent on just MRI. Uh,
That's one of the tests. Sorry, you're taking
gadolinium,
a note.
gadolinium. But acoustic neuroma is just not a problem. But I have an interest because the vertigo is due to vestibular nucleus. So I have an interest in fMRI.
Oh, okay.
Yes.
Okay. Very
Uh,
good.
Last I have to hang out about the reciprocal causal relationship of laryngopharyngeal and reflux and eustachian tube obstruction. If you can read my article you can understand me now.
Hmm. Where is
Yes.
your article published?
Oh yes. I can
Is it published in a journal that we can?
let you know the
Yeah,
Yes.
please. Maybe our audience would want to
publication.
read it as well.
Yeah. Maybe you should send it to Curious. But he did, Aiden. He did a presentation, hangout on his paper,
Oh, very nice.
which has been published. We'll send you a copy of the hangout.
Very nice.
And Dr. Kim, maybe you could send Aiden a copy of the paper that was published.
All right. Any other questions for me, John?
No, I think it's a good overview. I wish I had a deeper understanding of what's going on, but
We'll go into more detail, in terms of, what are neurosurgeons trying to look at for epilepsy and stroke? What imaging procedures? What helps and what doesn't help? What are the pros and cons of the current state of brain tumor imaging? We'll go through these things as we develop Radiologist TV, and can also crowdsource and see what the audience wants us to bring to them, and we can do that over a series.
Okay, very good. So this is a good introduction to the future of brain imaging with Aiden.
Thank you very much. Thank you, John. Thank you, Dr. Kim. A pleasure to be here as always. Good to see you all.
Okay, we're going to have you back, Aiden. We'll continue with the series.
Thank you.
So thank you very much. Thank you, Dr. Kim, for coming.